Chairman, the purpose of this bill is to permit the Office of Drug Control Policy, or the ODCP, to adopt specific information technology reporting platforms for overdose reporting and to set shorter time limits for mandatory reporters. There is a committee substitute for this bill. The committee substitute clarified that all mandatory reporters are required to submit their report within 48 hours after the provider responds to the incident via the appropriate technology platform. Current law requires a quarterly report. The bill deletes mandatory reporters from a list of reporters required to submit a report, including pharmacies operating in the state, prosecuting attorneys, and departments of hospitals. Hospital emergency rooms are still listed as mandatory reporters under the bill. The bill defines the term information technology platform as the Washington-Baltimore High-Intensity Drug Trafficking Overdose Detection Mapping Application Program or other program designated by DHHR and legislative rule. The DHHR has legislative rulemaking in another code provision. The definition of overdose is defined consistent with the DHHR's definition, which is currently in a rule going through the legislature this session. And last, an opioid antagonist is defined in the rule.
Thank you, Counsel. Again, in similar fashion, I know there's people to speak to this both in favor of and maybe against this bill. So prior to calling up some members from the gallery here, are there any questions of counsel by any of the committee members? I see no questions. So is there anyone present I know that would like to speak in favor or against this bill? Come on up. Could you just identify yourself and tell us who you represent?
Chris Hall with the West Virginia EMS Coalition.
Hey, Chris, welcome to the committee. Could you please raise your right hand? Chris, do you swear the testimony you're going to give is the truth and the whole truth, nothing but the truth, so help you God?
I do.
Okay, Chris, go ahead and tell us what you think about this bill.
The EMS providers across the state have some concerns related to this bill. We think it's obviously well-intended, and collection of data to respond to the opioid crisis is certainly needed. But we feel like that this particular piece of legislation fails to consider the unique position of EMS providers compared to other first responders and other individuals that are responding to overdoses across the state. EMS providers are already required to submit to the state within 72 hours a full patient care report. So for every time we go out, we submit a report back to the state of West Virginia to the Office of OEMS. And our concerns related to this bill is it actually would require us to submit a duplicate report. We feel like that, if you're looking at the opioid situation and looking to collect data, this data that's contemplated in this bill is already available to DHHR through the reports that we are already submitting to the Office of EMS within 72 hours of every medical response that we provide. So we feel like that's an undue burden being placed on EMS providers. It's an unfunded mandate. We spent thousands of dollars 10 plus years ago when these electronic patient care reports were established, and providing the equipment, the training, et cetera, to our staff to do it. And we just don't think it makes sense at this point to require us to submit to another data platform when DHHR, we believe, should be able to coordinate within its existing agencies to generate these reports from the EMS providers.
Thank you, Chris. We'll have DHHR come up here, the Office of Drug Control Policy come up as well. But you up for some questions from the members of the committee?
Absolutely.
Okay, the Senator from Boone.
Thank you, Mr. Chairman. Chris, is there any way to get that down to 48 hours, the reporting type thing from 72 to 48 hours?
The existing legislative rule says 72 hours. There's been a lot of discussion over that in years on how tightly we can compact that time frame. It used to be longer. We got it down to 72 hours. The concerns there and why we're at 72 hours is that gives you some ability to account for weekends, holidays, et cetera, and particularly the smaller squads that don't have people on staff, they're in their billing accounting offices 24 hours a day, 7 days a week, or the volunteer squads are utilizing a third-party service to submit a lot of their data and their billing.
And of course, you see the whole idea is to try to get as real time as possible in case you get a bad batch of, a carfentanil-laced batch of heroin, and if you wait sometimes 3 days, you might end up.
From that perspective, though, then you may be looking at the wrong place to gather that data. If you're looking for ultimate real-time data, 911 centers is a great place to get that because they're doing the dispatch the majority of the time for our squads anyway.
Okay, thank you.
Thank you, Senator. Senator from Jefferson?
Yes, actually, I think the senator from Boone asked kind of what I was going to ask, but I appreciate you being here. Thank you.
Chris, there's no more questions. Thanks for coming.
Thank you.
About Mr. Hanson? Just want to identify yourself for the committee.
Bob Hanson, Director of the Office of Drug Control Policy.
Bob, thanks for coming. You just raise your right hand for me, Bob. You swear the testimony you give is the truth, and the whole truth, and nothing but the truth, so help you God?
I do.
Thanks, Bob. Could you just go ahead and give your little spiel, maybe even also address some of the whatever was said by the EMS providers, and see if we can get to an agreement here?
Yes, I think this bill is a positive step because we're moving closer to real-time data, so it's more usable. And I think with the language in the bill about alternative platforms, I agree with Mr. Hall that we don't want to have duplicate record keeping and data systems, but if we can build on his system and then use the Baltimore system for law enforcement, I think that it can all work. So I think there's an alternative so there isn't duplication of record keeping.
I have a question for you.
Sure.
So we have reporters, okay, the required reporters, the EMS, the emergency room departments that council was talking about, the medical examiners. Inappropriately, pharmacists were removed from that list, and prosecuting attorneys were appropriately removed from that list.
Yes, sir.
Are they all reporting at 72 hours, or some reporting quarterly and some reporting at 72 hours? Because not everyone goes through an EMS. Some people get dropped off in an ER. Some people show up in the medical examiner.
Because the requirement now is for 3 months and a quarter, so people are recording on a monthly or longer time basis. And I think that's why this bill is really important, so we can get closer to real-time data and use that data and to make good decisions around the overdoses.
So we're getting some of the data
Yes,
at
sir.
72 hours.
I believe so.
But some of the data, a nice chunk of the data is coming in quarterly.
Yes, sir.
And it depends on who the reporter is.
Mm-hmm.
EMS is coming at 72 hours. All the others are coming quarterly.
That is,
Just
I
to
think so.
I just want to clarify that for the committee. The senator from Jefferson has a question.
Yes, thank you, and thank you, Mr. Chairman. Sorry, I hear this reverb. The goal is to get to as close to real time as possible. Are there any consequences if you're not able to, though, in this bill?
I do not believe so. No.
So okay, so what would be the situation, like Mr. Hall was saying, where they don't have staff, or it's a weekend, or an issue like that?
Yeah, I think we need to be reasonable. That's a legitimate concern, especially in our rural areas. But, the whole goal would be get as real time as we can.
Possible.
Yes.
So does the bill allow for that kind of flexibility?
I don't think at the present time, perhaps, Council.
Okay. I appreciate.
The current language allows for a 48-hour after the provider responds. So it's a 48-hour turnaround time frame for the data to be reported. And that's a move from quarterly.
Okay, but what are the consequences if it's not in by 48 hours?
There's no fine or penalty or anything like that
well,
attaches to that.
That's kind of what I was trying to get at. I mean, I understand the situations where it might not be possible, and I just wanted to, as long as we know that we're heading towards that goal and make that set clear, but there not be any kind of repercussions if there's a situation. So thank you, Council.
And I think the 48 hours came from, in terms of designing timeframes around quick response teams, which is the goal for the use of the data. In terms of reaching out to people, that was the time frame that has been established as, in terms of reaching back out to people, is a good time frame to reach people. Anytime after that, it's really not, doesn't help. So 48 hours was really the goal set to reach out to someone after they've experienced an overdose. I
understand.
Okay. Thank you, Senator. Mr. Hanson, one question for me, and maybe then one from the junior from the 17th. It would still be a positive if we moved everyone to 72, would it not?
Yes, sir.
I thought so too. We'll maybe talk about that during the amendment stage. The junior senator from the 17th.
Thank Thank you, Mr. Chairman. Thank you, Director. You know, I thought a year or two ago we passed a bill that said that any overdose had to be reported on the BOP, the Board of Pharmacy Reporting. Are you familiar with that, or am I mistaken?
I'm not familiar with that, sir.
Okay. Who has the access to this data? I know DHHR, and I would imagine your office being part of that, but does clinical physicians have access to this data?
No, sir, not at the present time. No.
Okay. So I guess one of the problems that practicing physicians have is if you take, for example, Senator from Boone or something. I'm have an overdose in the intensive care unit on the ventilator on a Friday. We get them off the ventilator. They're discharged on Sunday, and on Monday they're sent back in the senator's office with them having no knowledge of what had just happened, where they had an overdose, asking for pain medicine and presenting a good case. Would you be opposed to us being able to access this, much like the Board of Pharmacy? We can ask or tie this in somehow to the board. I don't even know if that's possible, but.
So is this Brian? You want?
There's a new provision that does make the data collected pursuant to this bill made available to law enforcement, local health departments, and emergency medical service agencies. That's new language.
But not private clinicians.
No.
Because I know I'm sure the ER physicians would tell you the same thing. Is you'll have people doctor shopping and they go to one local hospital and maybe they've got an old kidney stone or they've got something on there that can certainly trick you to make you think you have an acute problem. Then you're right down at the next ER. If there was some way to share that data, make it local, I don't know if this would be the vehicle to put it in, but I guess the big question was, would you be opposed to?
I think that there is an initiative going on.
There's a related
Could you
effort.
identify yourself
Yes.
for the people?
I'm Dr. Kathy Slemp, Commissioner and State Health Officer for
Hey,
Bureau of Public
Kathy, would
Health.
you raise your right hand? Do you swear that the testimony gives the truth and the whole truth, nothing but the truth, so help you God?
I do.
All right, thanks, Kathy. Go ahead.
Just wanted to explain, there actually is an initiative to do that, which we are trying to take the overdose data that's reported and link it in the PDMP so that we actually send a notification to the provider who's been the prescriber of record in the last several months, so that they get a notice that there's been an overdose and that we have some guidance around handling that situation. So that is not in place right now yet, but we've got an effort underway to do that, to get that linked back.
And will that, on the PDMP you're talking about, so that'd be the BOP report, right? The Board of Pharmacy Reporting, when we look up okay, so if.
But it would actually be sent, there would be a letter that would be sent, or is a notification to the provider directly.
Okay, but there will be, so currently on the Board of Pharmacy Reporting, if I'm going to write a scheduled medication for a patient, I'll be able to access that Board of Pharmacy report. I can also access other states that I feel maybe the patient has been to, or at least I understand that's how it can be done, correct?
Now, I'd have to, for the Board of Pharmacy, in terms of interchangeability across state lines. I know we would be doing it for if we received an overdose report, that we would then link that to the PDMP, the CSMP provider of record.
Okay.
I can't speak to the cross-border ability to do that at this point, because I think this is actually a very novel. I think we're one of the first states to think about doing this. So we're just kind of getting this in place and I don't know that it's happening across the country yet.
No, it's happened in one. I just came from an NCSL conference, and we talked to a lot of states, and they're reporting this on the PDMP, which was, I thought we did this 2 years ago, and it's still not showing up on ours.
You mean the use across, looking up your providers across borders, or you mean the notice of an overdose occurring?
Notice of overdoses on.
Okay, that I don't know.
Okay, and then so the primary physician would be notified if there's a overdose or suspected overdose situation by EMS, hospitals, police. But then what about other physicians? Let's say this individual 2 months later after having overdose comes into an orthopedic surgeon and needs minor knee surgery or something like that. When they access the PDMP, will that still show up to them, or was that letter only sent to the primary care?
You know, I like the idea. I don't know yet. would need to talk to our folks that are working on this effort to see how extensively it would be available. But we can certainly take that recommendation back and think how to do that.
Yeah,
I don't have it. I wasn't thinking nobody's going to speak to this issue today. I just, when the issue came up, I wanted to make sure that you knew that we were working on an initiative to ability to get that information back into the PDMP.
Okay.
Yeah. I'm sorry. I can get back more if you want it, how it's currently being designed, if you'd like.
Sure. Thank you.
Thank you.
I see no more questions. Thanks for coming.
We can also, and you could propose an amendment to add to this language if you would like it clarified regarding who can get
Is there,
for physicians.
the EMS is squirming around back there, so I'd like to give him a chance to come on back up if you had something else you want to say.
I have
You've already
Chris
sworn
Hall,
in.
West Virginia EMS
Thank you.
Coalition.
Go ahead, Chris.
One other thing, and I haven't had an opportunity to see the committee substitute the council prepared, but if looking at the bill as introduced, if the goal of this is try to get that information much quicker, particularly from other providers, non-EMS providers, as drafted, if I'm reading this properly, the 24-hour requirement was placed in C1, and it was only attached to the EMS providers. So I want to make sure that if you're trying to get that from other providers, or if you're looking at possibly a 72-hour amendment or whatever, that you're actually, with this bill, you're not putting that 24-hour, 72-hour requirement on us, get us into some kind of duplicated data reporting situation, but you're not capturing that from the other providers and mandatory reporters in the bill.
Thanks, Chris. Hey, Council, would you do me a favor and just clarify for every member on the committee the exact hours of this bill, what this bill does, as it's presented in the committee substitute. So, because I think we're all getting a little bit confused on the.
And so, the original bill that was introduced, as he stated, was just a 24-hour period with respect to EMS only. And so, when we did the committee substitute, we put it in 48 hours with respect to all mandatory reporters.
Okay.
So the committee substitute was 24 hours. It's now 48 with respect to all mandatory reporters.
Okay, right. So as the bill before us today changes it from quarterly to 48 hours for everybody across the board.
Right.
Okay. And we may revisit that in the amendment stage. Is there any further discussion or questions of council? Are there any amendments? Senator from Boone.
Thank you, Mr. Chairman. Again, I think with respect to the EMS concerns and the weekends, et cetera, rurality of West Virginia, if you would, that I move to amend the 48 hours to 72 hours.
Okay, Council, conceptual amendment from the Senator of Boone. Do you have that amendment?
Yes, so on page 1, line 2, the 48 hours would be struck and the 72 hours would take its place. So
in essence, then, EMS, ERs, medical examiners, everyone is required to report will have the same time frame of 72 hours.
That's
Is that correct? Okay.
Yes, that language applies to all mandatory reporters.
Is there any discussion on the Senator from Boone's amendment? Or any amendments to the Senator from Boone's amendment? All those in favor of the Senator from Boone's conceptual amendment, say aye. Aye. Those opposed, say no. Opinion of the chair, the ayes have it. Declare the amendment adopted. Council, if we could just please add that to the committee substitute and incorporate it into the committee substitute, that would be great. Now I recognize the vice chair for a motion.
Thank you, Mr. Chairman. I move that the committee substitute as amended for Senate Bill 520 be reported with recommendation that it do pass. Or should we enroll it into the committee substitute?
That's fine. Okay. All those in favor of the vice chair's motion, say aye. Aye. Those opposed, say no. Opinion of the chair, the ayes have it. Declare the motion adopted.